थायराइड डिसफंक्शन एंड रिप्रोडक्टिव हेल्थ पे टॉग है एंड इट्स बहुत इम्पोर्टेंट पॉइंट्स हैं, सो इट्स वर्थ रीडिंग इट। इंट्रोडक्शन में thyroid hormones they act systematically to control metabolism because function of thyroid gland is under the control of hypothalamic pituitary axis. Changes in thyroid function can impact generally on reproductive function before, during and after conception. Thyroid disease is the most common endocrine condition affecting women of reproductive age. Thyroid gland and abnormalities of the thyroid function. The thyroid gland control rate of the metabolic process throughout the body by the production of two hormones, T3 and T4, triiodothyronine and thyroxine. These hormones they also have key roles in growth and development, particularly brain development. Thyroid hormone release under the control of the hypothalamus and anterior pituitary. Thyroid disease is classically divided into hyperthyroidism and hypothyroidism, and the causes of thyroid disease are numerous. It is also a subset of patients who are euthyroid and have positive thyroid autoantibodies. The role of these antibodies in reproductive health has received increasing attention. Okay. Subfertility affects between 1% and 5% of couples worldwide. Thyroid disease has been associated with subfertility, although national guideline does not currently recommend routine measurements of thyroid function in asymptomatic women presenting with subfertility. Routinely, it's not recommended. High risk group में those with family history of hyper or hypothyroidism, thyroid surgery और autoimmune disease उनमें कराना इट्स कैन से हाई रिस्क ग्रुप है, उनमें करा सकते हैं रूटीन like measurement of thyroid function in asymptomatic women presenting with subfertility is not recommended. Hyperthyroidism, both clinical and subclinical, is thought to be found in approximately 2.3% of women presenting with subfertility, compared with the incidence of 1% of women in the general population. The link between hyperthyroidism and menstrual irregularity is well established. It is most frequently associated with hypomenorrhea or polymenorrhea. The likely mechanism for these menstrual disturbances is an increased sensitivity to gonadotropin-releasing hormone, resulting in a raised level of luteinizing hormone and sex hormone binding globulin, causing a rise in total estrogen. However, these thyroid-induced changes in the hypothalamo-pituitary-ovarian axis do not appear to be associated with anovulation, and most women with hyperthyroidism remain ovulatory. Although the treatment of hyperthyroidism in subfertile women is advisable for general health and to improve pregnancy outcomes, there is no evidence that treatment of either clinical or subclinical hyperthyroidism improves rates of ovulation. The impact of treatment of hyperthyroidism on pregnancy rates in the subfertility setting is yet to be assessed. Importantly, radioactive iodine is commonly employed treatment for hyperthyroidism, particularly Graves' disease. Radioactive iodine has not been associated with deterioration in gonadal function or adverse outcomes in offspring. However, postponement of the pregnancy for at least 6 months after treatment is necessary. It's MCQ. Hypothyroidism is common with overt hypothyroidism affecting 0.5% of women of reproductive age. Mild thyroid failure or subclinical hypothyroidism has a prevalence of 2 to 4% and is characterized by raised serum thyroid stimulating hormone of more than 4.5 milliunits per liter in combination with a normal T4. Thyroid stimulating hormone will be obviously high raised होगा in combination with a normal T4. And no clinical symptoms, ये subclinical hypothyroidism है. No clinical symptoms एंड TSH ज़्यादा होगा, जबकि T4 जो है विद इन अ नॉर्मल रेंज हमारे पास होगा। Hypothyroidism is known to affect pulsatile release of gonadotropin releasing hormone and is required for cyclical release of FSH and luteinizing hormone and subsequent ovulation. Hypothyroidism in childhood and adolescence is associated with a delay in reaching sexual maturity, and in adulthood associated with menstrual disturbance, particularly oligomenorrhea, menorrhagia, amenorrhea, in some cases, and ovulation. Additionally, thyroid hormone receptors are known to be expressed by ovarian granulosa cells, cumulus cells, and oocytes themselves, and may have a role in enabling activation of luteinizing hormone receptors and progesterone production. Hypothyroidism may also alter feedback to the pituitary by changing estrogen metabolism and circulating levels of sex hormone binding globulin. There is evidence of a dose-dependent association, with women with higher serum TSH levels having greater menstrual disturbance and anovulatory cycles. Women presenting with subfertility also appears to have raised mean serum TSH levels and increased rates of subclinical or overt hypothyroidism compared with the controls. This is compounded by increase in the T4 binding to thyroxine binding globulin in response to rising estrogen levels as a result of controlled ovarian hyperstimulation, potentially tipping normal euthyroid women into temporarily hypothyroid state. There is a suggestion that raised levels of serum TSH may be associated with reduced rates of fertilization. There is a suggestion that raised levels of TSH may be associated with reduced rates of fertilization during assisted conception and reduced pregnancy rates. Overall, in a woman with serum TSH of more than 2.5 microns per liter, improvement in implantation, pregnancy, live birth rates has been reported following treatment with levothyroxine in those with overt and subclinical hypothyroidism. However, even following thyroid replacement therapy, egg number and fertilization rates, implantation, pregnancy, live birth rates appear to be reduced compared with euthyroid controls. On the basis of this evidence, there has been a recent shift in practice to maintain serum thyroid stimulating hormone level below 2.5 microns per liter preconceptionally in the subfertility setting, in line with the American Thyroid Association for the first trimester serum TSH. तो ये टेबल है कॉजेज ऑफ थायराइड डिजीज, हाइपोथायराइडिज्म और हाइपरथायराइडिज्म. इट्स वेरी इंपॉर्टेंट टू नो द कॉजेज ऑफ हाइपर एंड हाइपोथायराइडिज्म. फर्स्ट causes of thyroid disease, hypothyroidism. In hypothyroidism, primary hypothyroidism. In primary hypothyroidism, autoimmune disease, autoimmune में atrophic thyroiditis and Hashimoto-thyroiditis is very Hashimoto's is common and very important to know. Other than this, iatrogenic में रेडियोआयोडीन थेरापी से हाइपोथायराइड हो गया, थायराइडेक्टमी, एंटीथायराइड ड्रग्स, इससे भी हाइपोथायराइडिज्म हो सकता है. ट्रांजिएंट हाइपोथायराइडिज्म इसमें सब एक्यूट डिक्वेरेंस थायराइडिस एंड पोस्टमार्टम थायराइडिस है एंड आयोडीन डेफिशिएंसी. ट्रांजिएंट में सब एक्यूट डिक्वेरेंट थायराइडिस एंड पोस्टमार्टम थायराइडिस एंड अलग से आयोडीन डेफिशिएंसी. सेकेंडरी और टर्शरी. सेकेंडरी हाइपोथायराइडिज्म में पिट्यूटरी फेलियर और पिट्यूटरी ट्यूमर सेकेंडरी है एंड टर्शरी में फिर हाइपोथैलेमिक फेलियर. सो हाइपोथायराइडिज्म की कितनी टाइप्स है? प्राइमरी, सेकेंडरी, टर्शरी. प्राइमरी के केसेस हैं जो थायराइड से ही रिलेटेड है. ऑटोइम्यून डिजीज जिसमें एट्रोफिक थायराइडिस एंड हाशिमोटो-थायराइडिस. आइटोजेनिक में रेडियोएक्टिव आयोडीन, थायराइडेक्टमी, एंटीथायराइड ड्रग्स. ट्रांजिएंट में सब एक्यूट डिक्वेरेंस थायराइडिस एंड पोस्टमार्टम थायराइडिस, आयोडीन डेफिशिएंसी. सेकेंडरी हाइपोथायराइडिज्म में पिट्यूटरी फेलियर एंड पिट्यूटरी ट्यूमर एंड टर्शरी हाइपोथायराइडिज्म में हाइपोथैलेमिक फेलियर. अब हाइपरथायराइडिज्म के कॉजेज क्या है? ऑटोइम्यून ग्रेव्स डिजीज, टॉक्सिक नोडुलर गोइटर, टॉक्सिक एडिनोमा, सबएक्यूट थायराइडिस, आयोडीन डेफिशिएंसी एंड ड्रग्स लाइक एमिड्रोन एंड लिथियम. सो दोबारा रिवाइज करते हैं हाइपरथायराइडिज्म की टाइप कॉजेज. ऑटोइम्यून में आता है इसका ग्रेव डिजीज, जबकि इसका हाशिमोटोज थायराइडिस एंड ऑटोइम्यून थायराइडिस है. और टॉक्सिक नोडुलर गोइटर, टॉक्सिक एडिनोमा, सबएक्यूट थायराइडिस, आयोडीन थेरापी, ड्रग्स, एमिड्रोन एंड लिथियम. Thyroid autoantibodies. Thyroid autoantibodies, autoimmune conditions implicated in subfertility and reproductive health include antiphospholipid antibodies, diabetes mellitus, and systemic lupus erythematosus. There has been long-standing speculation over the importance of thyroid autoantibodies in subfertility settings. Autoimmune thyroid disease is the most common cause of hypothyroidism in women of reproductive age. Thyroid autoantibodies are present in almost all patients with Hashimoto's thyroiditis, two-thirds of those with postpartum thyroiditis, and three-quarters of those with Graves' disease. Thyroid autoimmunity is thought to be present up to 25% of the general population. The prevalence of thyroid autoimmunity has been found to be constantly increased in the subfertile population compared with fertile controls and is found to be high in those with endometriosis and polycystic ovarian syndrome. It is well established that a proportion of people with autoimmune thyroid disease have a normal serum thyroid-stimulating hormone. It has been suggested that thyroid autoantibodies are an early sign of lymphocytic infiltration, therefore a predictor of thyroid disease. Increased rates of subfertility are also seen in youth thyroid women with autoimmune thyroid disease, and it's the management of this group that has created the greatest debate among clinicians. Autoimmune thyroid disease has been consistently associated with poorer outcome in the fertility setting in thyroid women, and specifically in those undergoing assisted conception, including lower fertilization rates, poorer embryo quality, and lower pregnancy rates. Although it appears that autoimmune thyroid disease is a precursor to overt thyroid disease, there is no significant fluctuation in serum TSH during the course of assisted conception. Treatment is either autoimmune thyroid disease positive women or control. Therefore, it seems unlikely that these differences in outcome can be explained by women being pushed into a temporarily hypothyroid state during treatment. Antithyroid antibodies have been found in the uterine follicular fluid of women with autoimmune thyroid disease at levels that correlate with serum antibody level. Possible mechanisms that proposed for this apparent reduction in fertility include an increased T cell population within the endometrium, polyclonal B cell cross-reactive trophoblast placental tissue vitamin D deficiency, which has been associated with lower success rates following assisted conception, and thyroid autoimmunity. Natural killer cell hyperactivity and migration to the uterus and cross-reactivity with placental and zona pellucida antibodies. Alternatively, autoimmune thyroid disease may merely be occurring concurrently with other autoimmune conditions that are known to affect fertility or may coexist with other conditions associated with subfertility such as endometriosis or polycystic ovary syndrome. There is a little evidence that suggests whether treating euthyroid women with autoimmune thyroid disease with thyroxine replacement therapy in the assisted reproduction setting improves outcome. Okay, so another analysis of 418 women, no improvement in implantation and pregnancy rates were demonstrated with treatment in thyroxine. Okay. Management of thyroid disease in the subfertility setting. Given the above evidence, it seems reasonable to measure thyroid function routinely in women presenting with subfertility. Thyroid function test, if done in women presenting with subfertility, it has a significance in subfertility, like if the patient is high risk group. Initially, this should include a serum TSH measurement only. Given that improvement in reproductive outcomes are seen in those in whom the serum TSH is less than 2.5 microns per liter, serum thyroid stimulating hormone level should be maintained below 2.5 microns per liter for those with both clinical and subclinical hypothyroidism. A first finding of subclinical hypothyroidism, serum TSH of more than 2.5 microns per liter with normal T4 should prompt a repeat serum TSH level and for thyroid autoantibodies to be checked. If the serum TSH persists above 2.5 microns per liter, treatment with levothyroxine is warranted to bring the TSH below 2.5 microns per liter. The dose of levothyroxine should be titrated until the serum TSH is brought to 2.5 micrograms per liter or less, and during this period, monitoring of levothyroxine TSH every 6 weeks is warranted. The evidence is lacking over the benefit of commencing levothyroxine in those who are euthyroid with autoimmune thyroid disease. It should, however, prompt close monitoring of thyroid function if pregnancy results and monitoring of fetal well-being and subsequently neonatal review. Miscarriage. Miscarriage is common, affecting approximately 1 in 5 pregnancies. Recurrent miscarriage is defined as 3 consecutive miscarriages affecting 1% of couples. Given that thyroid hormone plays an important part in embryonic development, particularly neurodevelopment, and thus until 10 weeks gestation, the fetus is dependent on vaginal transfer of T4 from the mother. It is unsurprising, perhaps, that thyroid disease has been long associated with the miscarriage. Thyroid hormone receptors are also known to be present on the placenta, suggesting it may have a role in placental development. However, there has been previously insufficient evidence and cessation of warrant routine screening of thyroid function in asymptomatic women presenting with the recurrent miscarriage. Hyperthyroidism. Hypothyroidism. Physiological changes of pregnancy, including increased levels of thyroxine binding globulin in response to estrogen stimulation, coupled with reduced clearance of thyroxine binding globulin and increased GFR rate, increasing clearance of free thyroid hormones, results in a reduction in the circulating levels of free thyroid hormones. The requirement for thyroid hormone production is therefore greater. This can be compounded by relative iodine deficiency, resulting from increased renal clearance and placental transfer to the fetus. A normal thyroid gland will be able to compensate, however, a thyroid gland which is already underactive or where there is subclinical hypothyroidism may not be able to adequately compensate. However, there is no evidence that overt or subclinical hypothyroidism are increased in those with pregnancy or recurrent pregnancy loss. Studies have attempted to establish whether treatment of women with subclinical hypothyroidism with thyroxine reduces miscarriage rates. Although these studies have consistently found significantly lower miscarriage rates in those women with subclinical hypothyroidism who are treated with levothyroxine, none have evaluated thyroid autoantibody negative women separately from thyroid autoantibody positive ones. It is therefore difficult to draw conclusions on the effect of treatment in women with autoantibody negative subclinical hypothyroidism. Thyroid autoantibodies. A 2011 systematic review and meta-analysis has confirmed the association between autoimmune thyroid disease and euthyroid women and miscarriage, with an apparent threefold increase in the odds rate of miscarriage in women positive for thyroid autoantibodies. The exact mechanism for this apparent increase in miscarriage rates is not clear. However, it has been suggested that because autoimmune thyroid disease is thought to be an early sign of thyroid disease, these women may have reduced thyroid reserves in pregnancy when demand for thyroid hormone increases. A few studies have suggested the impact of interventions including administration of IV immunoglobulin and thyroxine placement on miscarriage rates in women with autoimmune thyroid disease. This suggestion that low-dose thyroxine in these women may be beneficial in reducing miscarriage rates in women with and without a history of recurrent miscarriage. However, studies to date are small and no firm conclusions can be drawn from this. Management of thyroid disease in those with recurrent miscarriages. On the basis of current evidence, screening of women with a history of recurrent miscarriage is warranted. Overt thyroid disease should be managed with levothyroxine replacement therapy and the serum TSH brought within the target range in pregnancy, that is at or below 2.5 microunits per liter. At present, there is insufficient evidence to support thyroid replacement in those with subclinical hypothyroidism and autoimmune thyroid disease. However, continuing research may more definitely prove a benefit in the future. Okay. Pregnancy have a profound effect on thyroid gland function. Serum beta human chorionic gonadotrophin, which rises sharply in early pregnancy, is closely related structurally to serum TSH. Hence, cross reactivity at the receptor stimulates thyroid hormone release and suppress serum TSH levels. Beyond the first trimester, serum beta HCG levels fall accompanied by rise in serum TSH. The physiological changes of pregnancy are such that the demand for thyroid hormone is increased as pregnancy progresses, making pregnant women with overt or subclinical thyroid disease more susceptible to derangement in thyroid function. Hyperthyroidism. Graves' disease is the most common cause of hyperthyroidism in pregnancy, affecting up to 1% of pregnancies. Often the diagnosis has already been made, but for those in whom the diagnosis of hyperthyroidism is made in pregnancy, it can be difficult to differentiate from gestational hyperthyroidism. It can be difficult to differentiate from gestational hyperthyroidism, which affects between 1 and 3% of all pregnancies and occurs because of stimulation of TSH receptors by the beta HCG. C2E4 levels generally rise in both conditions, but thyroid-stimulating hormone receptors antibodies are usually positive and diagnostic of Graves' disease. As free T4 levels tend to return to normal in the second trimester, supportive management is generally all that is needed in case of gestational hyperthyroidism, and thyroid replacement is not indicated. Is Graves' hyperthyroidism associated with adverse pregnancy outcome, including preterm delivery, preeclampsia, growth restriction, heart failure, and stillbirth? Women should be advised to achieve euthyroidism before planning a pregnancy. Conception should be delayed for at least 6 months after radioactive iodine therapy. For those on medical therapy, propyltyrosol is the preferred agent because of lower levels of teratogenicity. However, guidelines now suggest changing to carbimazole. In the second trimester, because of concerns over propyltyrosol associated hepatotoxicity in offspring, whichever agent is used should be kept at the lowest possible to achieve euthyroidism. Hypothyroidism. Hypothyroidism pregnancy is a relatively common condition with overt disease affecting approximately 0.5% of women and subclinical disease affecting 2.5%. Although more frequently in overt hypothyroidism, both overt and subclinical hypothyroidism are associated with an increased risk of adverse obstetric and neonatal outcomes. Because of the fetal requirement for maternal T4 until approximately 12 weeks of gestation, neurodevelopmental delay is particular risk in the infants. Very rarely in case of autoimmune thyroiditis, there is a risk of transplacental transfer of TSH receptor blocking antibody resulting in neonatal hypothyroidism. Evidence suggests that adequate levothyroxine replacement from early pregnancy in those with clinical subclinical hypothyroidism reduces risk of adverse outcomes to the background risk of general population. Thyroid autoimmunity. Thyroid autoimmunity. It is likely that euthyroid women with autoimmune thyroid disease have lymphocytic infiltration of the thyroid gland. It has been suggested that these women have a 5 to 10% risk of developing hypothyroidism in pregnancy as a result of increased requirement of T4 in pregnancy. Studies have suggested that euthyroid women with autoimmune thyroid disease have a 2-fold to 4-fold increased risk of preterm labor. At present, however, and this is the only prospective randomized trial comparing treatment with thyroxine, non-treatment control, routine retreatment of autoimmune thyroid disease is not recommended. Now this table, which contains complications of hypothyroidism in pregnancy, maternal complications with the neonatal complications. Maternal complications include anemia, postpartum hemorrhage, cardiac dysfunction, preeclampsia, placental abruption. It's hypothyroidism. And in neonatal, complications of hypothyroidism are fetal distress in labor, prematurity, low birth weight, congenital malformations, perinatal Congenital malformations, perinatal death, stillbirth, neurodevelopmental delay, congenital hypothyroidism if autoimmune. So what are the maternal complications? Anemia, postpartum hemorrhage, placental abruption, preeclampsia, cardiac dysfunction, and in neonate fetal distress in labor, prematurity, low birth weight, congenital malformations, perinatal death, stillbirth, neurodevelopmental delay, and congenital hypothyroidism. These are very important to remember. So, management of thyroid in pregnancy is although not currently recommended, there is evidence to suggest that routine screening of Indian population for thyroid dysfunction at the start of the pregnancy may be beneficial, as targeted screening of high-risk cases have been found to miss approximately one-third of cases of overt and subclinical hypothyroidism. At present, high-risk screening approach is currently adopted. For women at high risk should be screened. These are the high-risk women, and these should be screened. Family history of thyroid dysfunction, thyroid surgery, family history of thyroid disease, goiter, positive thyroid autoantibodies, clinical symptoms, signs of hypothyroidism, diabetes type 1, history of miscarriage, preterm delivery, other autoimmune disorders, history of subfertility, history of therapeutic head or neck radiation, age greater than or equal to 30 years, previous treatment with amiodarone, previous treatment with lithium, and recent exposure to iodinated radiological contrast agents. And these are the trimester specific reference ranges of the TSH. First trimester 0.1 to 2.5, it's MCQ. And second trimester is 0.2 to 3.0, and third trimester 0.3 to 3.0. The effect of physiological changes in pregnancy in the thyroid gland has led to the development of specific reference ranges for the thyroid function test in pregnancy. In women with previously diagnosed overt or subclinical hypothyroidism taking levothyroxine before pregnancy, the dose should be increased initially by 25 micrograms. This is also an MCQ. Once pregnancy is confirmed, to compensate for the increased T4 demand of pregnancy, thyroid function should be monitored every 4 to 6 weeks. Further increase in levothyroxine should be required to maintain optimal serum TSH. Women with pre-existing hyperthyroidism should continue anti-thyroid medication, should have thyroid function closely monitored and kept within trimester-specific reference ranges. Fetal growth and heart rate should be monitored, particularly in those with anti-thyroid antibodies because the risk of fetal hyperthyroidism. Babies of all anti-thyroid antibody positive women, whether hyperthyroid or euthyroid, should have a neonatal review after delivery because of the small risk of neonatal hyperthyroidism. As euthyroid women with autoimmune thyroid disease are increased risk of developing hypothyroidism during pregnancy. Current guidelines suggest that they should have thyroid function checked every 4 weeks in early pregnancy and at least once between 26 and 32 weeks. Okay, this will ensure prompt detection, treatment, reduce risk following delivery. Thyroid function quickly returns to pre-pregnancy levels, so levothyroxine therapy can therefore be changed to pre-pregnancy doses, but thyroid function should be rechecked to 6 to 8 weeks postpartum. Those women with Graves' disease often intend to relative omission towards the end of the pregnancy and will need to be assessed within 2 months of delivery, as they are at increased risk of recurrence or exacerbation of Graves' disease. Conclusion. So, thyroid disease can have significant effect on reproduction from conception to birth. However, with appropriate screening, a high index of suspicion, and prompt management, this can be significantly reduced if not ameliorated. The benefits of the LT thyroid stimulating hormone levels, if we do TSH in management of hypothyroid in fertility setting. If thyroid stimulating hormone is less than 2.5 micrograms per liter, less than or equal to, no further action is required. If thyroid stimulating hormone level greater than 4.5 micrograms per liter, we will check T3, T4 thyroid autoantibodies and will start levothyroxine and titrate the dose to bring the TSH the normal range. If TSH is between 2.6 to 4.5 microns per liter, we will repeat the TSH and thyroid autoantibodies. If TSH level less than equal to 2.5 microns per liter and negative thyroid autoantibodies, no further action is required. If thyroid stimulating hormone less than equal to 2.5 microns per liter and there is a positive thyroid autoantibodies, we will monitor thyroid function tests, fetal growth in the event of pregnancy, and if thyroid stimulating hormone greater than equal to 2.5 microns per liter, we will commence low-dose thyroxine. We will repeat thyroid function tests, and there is aim to keep the thyroid stimulating hormone level less than equal to 2.5 microns per liter. If thyroid and autoantibody is positive, we will monitor thyroid function test and fetal growth in the event of pregnancy. So this is the flow chart of the management of hypothyroidism in a fertility setting.